So, thank you very much. Thank you everyone for being here this afternoon. Welcome to my fantastic panel. Come on and take your seats as we have about 40 minutes to set the world to rights when it comes to health tech. So this is the health tech hijack, which is what I'm calling it, where we get to talk about all the great things that we're doing in the world of health tech and how we can go further, faster together. So I'm going to start, we've got a fantastic panel. I'm going to let them introduce themselves in a second. We have got a range from the very large companies to the just started out. We have got people who are working in more data and understanding the outcomes orientation of what we're doing to those who are delivering SaaS services today. So it's going to be great. If you have questions, please do put them into the Slido. So I'm going to start by asking the panel to introduce themselves and say who they are and where they come from. If we can start with André on the end, please.
Yes, hi, my name is André Rogaczewski. I'm the CEO and co-founder of Netcompany. We are based in Copenhagen, but we have offices across Europe, 8,000 employees, and we're delivering a lot of digital services to government, and especially within the health area as well.
Thank you.
So my name is Nader. I am the CEO and co-founder of Patchwork Health. We're based out of London, UK. And yeah, we build end-to-end workforce management platform for healthcare.
Yes, hello. My name is Dominik Stosik. Thank you very much for having me here. I'm by education a medical doctor. I'm from Poland and Germany both. I have 2 passports. And I'm also e-resident of Estonia, where the startup I founded and I'm the CEO is based, and we're actually trying to use the voice as a medical biomarker to prevent, monitor, and predict disease.
Fantastic. And finally, but no means least.
Stein, Olav, Skrøvseth. I'm the director for the Norwegian Center for E-Health Research. We're based in Tromsø, in the far north of Norway. Background as a physicist, have a PhD in physics that I have absolutely no use for in my daily life. But we work a lot on data and doing research on e-health implementation in both Norway and internationally.
So it sounds like we've got the right group of people here for this topic, which is fantastic. In the pre-meet, we had so many questions for each other. We won't get through them all, but we're going to try and get through as much as we can in the next 40 minutes or so. So the first question we have is around what tech innovations are having or could have the potential to have the greatest impact on health and well-being right now. And what could we do to accelerate that even further? So I'm going to let the panel have a few minutes on this topic, because it is essentially the key heart of what we're talking about here. If I can come to André first, what do you think is the key innovation that you're seeing from your perspective?
Well, let's be honest here. I think most societies, especially here in Europe, are sitting on a time bomb when it comes to health systems. So people don't really want to work in the health sector anymore. We have an elderly population, and we have a rise in chronic diseases. And we need to do something. And I think there's like 3 areas where innovation is happening and where technology really can benefit and change that crucial development. And that's one is, of course, data, prediction of diseases, but data and health data as such, that's definitely a gold mine where we can become much wiser at what we do. I think a second big trend at the moment that is really changing the way we look at hospital systems and elderly homes is e-hospitalization or home hospitalization. You see more and more companies and governments looking into that. I've heard politicians already say that in several countries in Europe that you want maybe even 30% of your hospitalizations to occur at home, where you are in a safe environment, you will not be infected by other diseases. We will monitor you electronically, maybe even better than we do at the hospital itself. And then finally, I think that the very important thing at the moment is how to get some relief into the people working in the health sector. So nurses and caretakers, people working physically with patients spend too much time not doing what they're supposed to do, either registering in old IT systems, which is a paradox. They're actually registering stuff in old IT systems in order to gather this important data, or they're doing administrative tasks, or maybe they're even over-educated in some cases in order to do what they're supposed to do. And here we also need technology to help them out. I see a lot of appliances here, voice recognition, but also things that just happens to help manage the whole process of being a caretaker on welfare technologies in that sense as well. So those 3 areas, I think you'll see an explosion actually. I'm absolutely sure about it.
And a very welcome and needed explosion of those technologies for what we're about to face in the next few years and decades. Anna, it comes to you. Well, I mean, maybe picking up some of those themes with workforce and making the job doable and sustainable and satisfying.
I mean, it's very interesting, André, what you were saying about how the first generation of IT that came to healthcare probably slowed us down, didn't speed us up. And often that kind of a path of digitization wasn't necessarily very obvious in the early days. It was digitizing a paper process rather than actually rethinking the process. But I think what we're seeing right now, at least from the perspective of my world, is a complete rethink of our staffing models. So we're obviously facing a staffing crisis, as you've mentioned. The rising demand for healthcare, really with the old model of delivering it, is not meeting it. And we're seeing 2 big trends. The first one is a very different way of thinking about the role of the clinician, whether it is the boundaries between the traditional professions of doctors and nurses and therapists, and really appreciating the skills mix they bring in rather than the professional designation, and how then they could be deployed within healthcare organizations in a different way. And the second is how clinicians are employed within the system. Historically, again, compounded to very brick and mortar hospitals or clinics, and very limited in their scope. We're seeing right now integrated care systems coming together, expecting care to be delivered across the entire population, requiring a very different approach in staffing our hospitals. Now, obviously, that requires a fundamentally different set of technologies that look at things like passporting, allowing clinicians to move borderless across organizations. We've seen a bit of that during COVID, which was, again, one of the silver linings of that pandemic, is just accelerating concepts that have been talked about for many years but never really implemented. So passporting clinicians, of course, across multiple employers has enabled that workforce resilience within a system, bringing the hybrid work of physical and virtual care, and enabling staffing systems to be able to cope with that. And finally, as I said earlier, rethinking how organizations plan and deploy their workforce based on this evolved need, and really equipping their clinicians with the right digital tools. So we're seeing some acceleration there. It is still fragmented. It is still occasionally just hotspots of innovation that hasn't necessarily seen the level of scale on a national level, but there's some promising and exciting stuff in that space.
Exciting to see it, the potential for scale, and it's maybe just there, tantalizingly close.
Absolutely.
Excellent. We've got one of our startup community who's doing something very different with tech. So explain to us what you're doing, Dominik.
Yeah, I may explain it while picking up 2 very, very interesting arguments from the colleagues. Like, the first one was the explosion. Like, we have to think why. When we look at academic papers, like, they are exploding, like they're going, when you do a research in PubMed, they're like skyrocketing. But the AI applications, they are still hidden in some laboratories, and they're not yet brought out into the market. And we have to think why this is like that. And we at attained.ai, we believe that the human voice carries much more information than we actually are capable of processing. And I apologize, but I have one definition I had to write down because it's insane to remember this by heart. Last week at a conference, I met a data scientist, and I asked him what actually is his job. And he was not very sure, so we had to find the official definition, and I will allow myself to read this. So data science is an interdisciplinary field that uses scientific methods, processes, algorithms, and systems to extrapolate knowledge and insights from noisy, structured and unstructured data and apply knowledge from data across a broad range of application domains. So what this basically means is that we have a lot of data, but we're wasting a lot of data because we're not using them. So I think we want to add an additional layer. We don't want to develop a product which will diagnose because this is too early. We are not that far because there is in the community, what people don't understand, they are maybe kind of afraid of, so this is something we have to work on about. And about COVID, it didn't only accelerate, it also amplified what actually is going wrong. And it has shown us that we have a problem with the aging society and with the treatment of these people. And this is why we picked the topic with the biggest pain, which is cardiovascular disease. And cardiovascular disease is the leading killer in the world. It's not cancer, it's cardiovascular disease. And the earlier you can find out that someone is suffering from this, the better you can treat them. And 1/3 of the whole population in the world dies at a very young age from the consequences. And what else is important to say, that over 75% are from low and middle countries, so they don't have the access. So I think this is something we could try to make this more accessible to the public.
Thank you. And it's great to see sort of new applications, new science being taken to something so ubiquitous, something that's affecting so many lives around the world. It's fantastic to see that application and give hope in different new ways. Can I come to you, Stein, Olav? And so what do you see as the biggest tech innovation or that's having an impact today or has a potential to have impact in the near future?
Right, so I think maybe one of the fundamental problems we face in healthcare is the access to the right information at the right time. A lot of healthcare professionals and patients are working and doing perfectly well with the problems that they have, but they don't have access to the right information at the right time. And HealthTech can help us save that in one way, but we also need to lay the foundation, and that is a government job, to how do we speak the same language, how do we share data, how do we put the right data in the right place, in the right hands, and so we can use them for AI or whatever purposes comes up right then. Because it is a struggle to get all this information coordinated and get coordinated care services. In Norway, one big impact project is a shared medication list. It's something you would think was in place a long time ago. Yeah. It sounds like such a simple problem, a list of each patient's medication, but that doesn't exist, at least in Norway, and I know this is an international problem as well. So having that shared medication list, that everyone agrees that this is the medication list. It's a big project for a quite simple problem, but it's the most important problem that we can tackle in order to raise quality and save lives. And it's not exactly a high-tech, exciting problem in that sense, but you need the foundations for the data sharing, you need everyone to coordinate, and everyone working together, and it's not always in the interest of the person who puts in information that gains the most out of the solution, but everyone has to pull together to get this solved. It's just that important. So that's an example of a relatively small scale, but big impact solution. But in the big terms of things, it is this problem of getting the information shared to the right people at the right time. And there are a lot of issues when it comes to that, legal ones not least, but yeah.
Yeah, and around patient trust and understanding what's happening with their data and being enabled to direct to a certain degree whether they want that to happen or not. So thank you very much for everyone. We're going to go a little bit off piece now. I wanted to pick up on a theme around breaking down the silos of the traditional models of care. We've picked up some of that already. It was very anatomically directed, sort of diagnosis-driven or physical location-driven, in the hospital, out of hospital. I just wanted to push the boundaries on that, on how do we see that changing? And I wanted to start with you as to maybe bring an example into this mix.
Right, so it's true that we tend to work in silos, and we tend to work diagnosis-specific. That's the tradition in medicine. And I'll relate a story. I work in northern Norway, which is a sparsely populated place with long distances and sometimes weather that's not very cooperative. We interviewed, or some of our researchers interviewed an elderly man, 75 years old, widower, who was living in a faraway place, many hours drive to the local hospital. 5 critical diagnoses, I can't list them all, but heart failure, renal failure, etc. It's not an untypical case, and we're going to get more of these cases as we go along. So this man had, during 1 year, he had 34 encounters with the healthcare system. He had 98 days in hospital. A lot of those were emergency day cares, so he had to be transported with helicopter into the hospital, extremely expensive. And he got good care for each one of his diagnoses. But none of those were talking together. None of the doctors that were involved in healthcare for each one of those diagnoses talked to each other. So he had a huge pool of medicine. He didn't know what all that was for, and a lot of interactions between them that nobody addressed, of course, making the problem even worse. And then we asked him, well, what's actually important for you? And one thing he said was to get the medication straight. He wanted to know what medications he was taking and side effects and get that settled. The other thing that was really important to him was that he had recently met a new girlfriend. But she lived some kilometers away, so he needed to drive. And he had lost his driver's license some years back. So the most important thing for him was to get the driver's license back. None of the doctors had ever asked that question or got that answer. What is the goal here? What's the target? One just assumes this is the target. If they had talked together and got this, it doesn't have to be sitting together in a room, preferably not, actually, but just having the means of communicating, having a shared digital platform that you can cooperate and work together so that you can actually address the problems. You need to address the purely medical issues, but you also need to ask, what is actually important to you?
I think that's a really key lesson, always asking, what outcomes are you trying to achieve? Because it might be very different for different people. I mean, André, I don't know if you want to come in on this. I mean, thinking about the e-hospitalization agenda, trying to deliver care, not just closer to home, but in the home, and some of the challenges that might face.
I think, well, e-hospitalization or home hospitalization has a lot of advantages, but what we're talking about here with the silos, and I mean, what is your biggest fear, really? I mean, your biggest fear as a citizen, or, well, potential patient, what is your biggest fear? That is, if no one knows who you are. They didn't really catch up on what happened last time. It could be your medical record. It could even be some simple things like your blood type if you end up in a traffic accident, right? And it all has to do with organization, and we need to reform our health systems, and then it has to do with technology. It's both, right? So if you go in and out of hospital, even home hospitals, and someone has to take care of you in the municipality level, for instance. Municipality level is not necessarily hospital level or federal level. They don't even talk to each other. If you don't have a common medical record or somewhere where you can look people's data up, you're lost. You have to give it in again. There's nothing worse as a citizen than coming to a hospital or being taken care of, and people are asking you again about something really basic, or asking you about something that happened 3 months ago. And you're like, why don't you know this? That's because it was your private doctor, it was your personal doctor, or this was I don't really care, you should know this. And when you're in that situation as a citizen, you really want to give your data. But when you're not sick and something is not wrong with you, you always, I mean, you have 20% of population right now being absolutely skeptical about giving in their health data. Even to research, even though it's anonymous, they're skeptical. And that number is growing. So it is a dilemma that we have. You know, we have an organizational view on this, which has to do with silos not working together. We have the technology, we have the means to have one record, one medical record. It just takes time, and we don't have time. And then we have a skeptical part of the population who are like, until they really need their data in those crucial situations, they will actually fight it. So we need courageous politicians, great organizational people that can diminish the barriers between the silos, and we need some practical, pragmatic IT as well, not only, you know, next generation IT. We need basic systems to be enforced where you can look up these things if I give consent. And where you start is, in Denmark, we have one place you can go to called health.dk. You log in with your personal ID. Everything about you is in there. You can see it yourself. Now, this is yours. That's your information. At least you have it there, right? That's the start. But that I think that takes a lot of courage from a lot of decision makers and also a great organizational people to get to that point, I think.
I think there's a challenge with mindsets, not only of the citizens, people, their health, and how they want to engage. And you're right, it's very personal, and it changes for that person. It can change whether they're well or not, whether their family is well or not, as to how they want to share data. And I think we've got to keep refreshing that consent, refreshing that question, in case it's a different answer, both because you used to give consent and now don't, or you didn't and now you want to. And I think we've got to keep that dynamic going. It comes to me to the change and the shift of from a professional perspective as well. We've seen this in the UK, England. We've got a view about opening up patient records, and there is a bit of a concern that maybe the things you had written in the past, maybe you wouldn't write them now in that way. If you knew they were going to be made available. And I think that mentally we've shifted a long way in the last 5 years. That is really starting to, it has changed. But Anna, it's coming from the workforce perspective. I'm going to pick on you now. How are the changes in silos helped or hindered by the way that we have traditionally employed people as clinicians?
Yeah. So I guess when we talk about breaking the silos, often the discourse is around outcomes-based care within the population, so population health, and outcomes-based care often is about creating accountable care organizations within the region that really rethinks around the care around the outcomes of the patients rather than the transactional nature of care historically, where each transaction is kind of isolated and handed over from one clinician to the other or one provider to the other. And I think we've made great strides in the last decade or so towards trying to kind of come towards that outcomes-based care model. However, our staffing model has always remained transactional, unfortunately. And often we haven't thought of staffing as an enabler of outcomes-based care. And whilst absolutely the conversation needs to be centered around delivering the right care to the patient around the patient's needs and around the outcomes for the patients rather than transactional aspect of traditional healthcare, I think our staffing models need to really deliver outcomes-based staffing that mimics that allows us to deliver on the promise of outcomes-based care. And what I mean by that is really rethinking the role of a clinician within the system. So basically, a good example of that would be often we see, at least in England, we see that model quite often. A clinician's cancer pathway could go through different primary care, secondary care, and tertiary care providers, and often the patient is ping-ponging through the system rather than actually bringing the right clinician, the right place, the right time towards the patient. And instead, the patient has to navigate that labyrinth of services provided in a complex environment. But the reason why that's there is not only because the systems were not set up to be around the patient's outcome. The clinicians were employed to serve a model that forced them to be working in silos in their own environments. And breaking that system to a truly outcomes-based staffing model, from our perspective, is allowing clinicians to move across boundaries of employment, boundaries of where they provide care, redefine the role of a clinician, especially in terms of the roles of primary, secondary care, doctors versus nurses versus therapists, and really blending it in a way that truly delivers on the outcomes based for patients. Now that definitely means there's a lot of policy work to be done here. I mentioned earlier passporting, basically allowing a clinician, especially in a system where there's a little bit a homogeneous employer model, like in the UK within the NHS. Once you get that blue tick from one NHS provider, you should be able to move around the system, but you don't. You're still treated every single time with all the red tapes. That hinders movement, hinders that outcomes-based model to be delivered at its best. Issues around defining a very rigid way of who's allowed to do what and where, rather than focusing on the skills of clinicians. I actually think in North America they've done a much better job at redefining a skills-based care model. So for example, we see a lot more nurse anaesthetists leading the care of patients in operating rooms. In many parts of Europe, we haven't seen that transition yet, but really focusing on the skills mix of your staff base that allows you to deliver the right outcomes, rather than traditional employment models of traditional professions of the boundaries of a doctor or a nurse or others. Now, underlying all of that is the need for a new technology approach to planning and deploying a workforce, to really be able to understand the capacity you have within your own workforce, the skills mix you have, the demand that's coming through the patient needs, and really being able to optimize your workforce deployment. So that should usher, hopefully, a whole new generation of staffing systems and workforce systems that are able to deliver on that outcomes-based approach rather than transactional
So once
approach.
you've set the policy and what you're trying to achieve, we have got tech examples and off the shelf, but also the ones in development that will help leverage and deliver that.
Yeah.
Once we've decided that actually we are committed to making those changes.
And for those, I think it ushers the opportunity for the true co-creation. Because I think at the moment right now, the conversation between innovators and the users of the systems are not happening in the right way. There are some pockets of that, and it's very promising to see the newer generation of innovators co-creating with the end user, the end user being really either the provider, the clinician, or the patient, co-creating the solutions of the future. But you're absolutely right. Once a certain policy agenda has been set and the red tape has been taken away, as we've seen in some cases during COVID, then and a co-creating environment is set up, then we can see quite an exciting...
We can move fast.
Absolutely, without breaking things.
And not break things. Too many. It's interesting, the sort of the tools. I'm going to come to you, Dominik, now on the tools of the trade. I mean, HealthTech, health has got so many innovations in the history, which you'd all be proud of, from the stethoscope onwards, even the pen and writing notes could have been considered a tool of the trade. The tools are changing, though. And how are we embracing that? And how do we support clinicians to embrace it?
That's a very good question, because I once had a professor who said that his grandfather didn't have a stethoscope to auscultate the lung. He was doing it with his ear, putting it on the chest, on the patient. So this is a very, very simple example, but it shows that the distance between, we're accelerating in this field. But I wanted to pick up something interesting you said about the holistic approach, because we have to rethink the way we are doing medicine, because we're not doing, as we should, I think, evidence-based medicine. We're doing eminence-based medicine, like some eminence here is telling us what to do. Let's say if you go to a doctor and say, my back hurts when I wake up in the morning, then a good doctor would say, try to get up in the evening. A bad doctor would give you painkillers, yeah? Obviously, the first one was a joke, but the second one is we're treating the symptoms and not the disease. I don't know why, but this is how it works at the moment. And I think we're smart enough to just one step, maybe not forward, but maybe let's say one step forward, and do not let the situation come so far that there is a disease we have to treat. So we can monitor and predict these things. And what I forget to mention is that there are really interesting technologies, like the University of Leeds has research where doctors who are examining patients, they're examining their eye, they can see by dilated vessels that they made a study that correlated the dilated blood vessels in the eye to have a direct impact on they reflect like the state of their coronary artery situation. And there's another thing, the cardiophysiology is also something, because it's very technical, like I'm a radiologist, but I had done my PhD in cardiology. So radiology, by definition, is very close to AI because it's very technology-based. But cardiology as well, so cardiophysiology is also at the forefront. And why I'm telling you this is that these tools are, they are so good that they see things before humans see them. And that's not, I know, I hear the critics, I hear everyone will say, I don't want to be treated by a machine, I want a doctor, but that's not the point. The final word is still the physician, yeah? And there were times where pilots had to fly and had a compass and maps, yeah? And now we have autopilots, and flying hasn't become more dangerous. And why I'm saying this with the cardioelectrical advancement that they're on the forefront, we have my former dean from my medical university. She's a member of the board of the International Society of Electrocardiologists, and she also is on the advisory board of our startup. Mm-hmm. And these things are advancing. And what COVID did, basically, COVID has shown how we can approach different methods. Like, someone doesn't have to go to a doctor 50 kilometers to get a prescription. But the other thing is, suddenly, a lot of startups started to try do things because COVID was a very, it's not a pandemic, it's evolution in my way, but that's just.
I think as the COVID has enabled us, I think you said it very well earlier, it says, and it accelerated some of the changes, but also amplified some of the issues. And I think was a really elegant way of articulating how COVID has been an opportunity, but it's also, it has necessarily actually just put a spotlight on some of the things that are yet to be fixed. Mm. So in the last 10 minutes, we're going to be talking about things that are yet to be fixed, or things we need to invest in. Are we investing in the right things to help accelerate the benefits that we are all seeking as part of the implementation of health tech? So I'm going to come to you, Stein, Olav, and start with, are we investing in the right things? If not, what should we, or what should governments be investing in to help us reach our potential?
If we're investing in the right things, I have no idea. But what I see we're investing in Norway at least, is large-scale EHR systems. There is now a big project in central Norway on procuring or implementing, actually, a common EHR system for primary care, secondary care, tertiary care. And it's, I've never ever seen before people walking in the streets with torches protesting against an IT system.
Oh, wow.
It sounds
not a great PR moment.
No, it's absolutely not. And this is the 100 million euro project, where the idea is really good, trying to get information shared across these different silos that we've been talking about, but is the implementation particularly good? It remains to be seen, frankly, but there has been a lot of objections, as you understand. What we should invest in is the common platform that we can build on, so that startups and bigger companies can come and contribute, but then we need that foundation, and that is absolutely the investment that we need to make.
And do we need to take the public, or the people for whom we deliver these services, on that journey with us? Like, if they don't understand, and we've had examples of this in England, we've not got it right. I think we've got it more wrong than we got it right sometimes. But are we bringing people on that journey? André, do you think we're investing in the right things?
I think we're investing a lot into wrong things, or at least investing into keeping the lights on. Mm-hmm. There's a lot of investment into just keeping the lights on. You know, just running the goddamn thing one more year.
And it's not negotiable, is it?
And it takes more, it takes reforms, as I said before, in order to do the right investments. And I think it goes on two levels. You have to invest into both human capital and monetary capital, into breaking down those barriers. We need to do that. And then secondly, when you've done that, you can free up for innovation where you can actually invest into something based on access to data and access to processes. Because right now, many of the health systems are kind of imprisoned into themselves, into some sort of one block system organizationally and technically. And it requires and takes some courage to do something about it, instead of just adding another layer on top of it and investing into keeping the lights on. So I think we'll see it happening, and countries are in different shapes doing. I mean, there are differences, and it's all about people, right? At some certain point of time, population will not accept anymore. I mean, when the quality level falls down, you have too many arrows, you have too many stupid things happening, and it becomes a media story, and we're all affected by it. Then you will have some sort, but before you get to that point, you need to have someone that are able to articulate and talk about these problems and find solutions for them. Simple medical record systems that are common for a geography or a country, one digital identity when it comes to health. Well, then stop talking about one digital identity for everything. Just start with health, at least. Or think about citizens owning their own data instead of trying to integrate 150 different IT systems. Then at least make an access to these IT systems from your personal level, and then you can share it when you get somewhere. You know, have the courage to think like that and start doing that in some areas instead of just talking about it. That's going to change things. If we don't do that, we're just going to add a little bit more into this expenditure that keeps the lights on, and eventually cannot hold. The structure cannot hold. We're just getting too old, too many chronic diseases, and seriously, a lot of people don't really want to work in the sector because it's not prestigious and it's too hard.
So shifting that. I mean, HealthTech's going to save the world. That's the title of the panel, right?
It will.
We will, but
it will.
It's going to save us from imploding. Is what you're saying. We have to make those shifts, and particularly with governments identifying the things that, from my perspective, only the government can do. It's not something that private business can say, right, we're going to get this done and find the case and the willingness to do it. There are things that sometimes only governments can do. And focusing on that, making that really work as an enabler to a whole range of things. You might not know what you're enabling yet. You can control it as you go. You may not see the full picture. It may not be in the full resolution yet, but you get the big shifts. I wanted to pick up on people's own investment in their own health. And I think that's something that pandemic has really helped to crystallize. We've always done this. It's not something new. But it is bringing out, if people want to invest in an asset, probably their best asset is their own health. For most people. And you want to, if you spend, some money on a takeaway on a Friday night, you would spend the same amount of money on your health if you knew it was going to make a difference, maybe more. how is anyone feeling about leveraging the investment that people are willing to make in their own health? For example, in private blood tests or wearables or anything else. Yeah. How do we, as an ecosystem, help support that in a way? Anas, do you have a view on that?
I mean, funny, we were talking about that earlier, about the quantified self and the rise of a generation of I mean, very soon, millennials technically are now as old as 40 plus. So give another 10 years and millennials are kind of going to be your biggest population with chronic illnesses. And their approach to health is very different to the previous generations. They're a lot more aware, they're a lot more obsessed about measuring it, and they want a lot more ownership. So you see, obviously, the rise of the wearables and the constant measuring of things through wearables, the at-home diagnostics where you can collect your quarterly blood test to measure your anywhere from your liver functions to your testosterone levels to everything else in between, which is great because it shows that there is a space for owning your own health and measuring your own health and keeping track of your own health. The pitfall here is twofold. The first one is that information sitting in silos. Does the GP have access to my records? Often, quite a lot of GPs don't even trust your arrhythmias reading on an iPhone or an Apple Watch and say, no, I want to send you for another one. And you have to go through that process. So how do you combine that information to your core records? And the second one is, if some of that's going to be out of pocket, are we making sure that we're not falling into the trap of access to healthcare, where only ones who are able to pay for certain capabilities are able to pay for it and others are not. So as long as we're addressing those as silos of information and access, then I think it actually could usher a whole revolution of patient-owned care.
Excellent. Right, we're at time, so I have one final question to go around. You've got super quick, like 10, 20 seconds each. If you could give governments one bit of advice that it could do something that would make a difference and help HealthTech save us all, what would that advice be? I'm going to start with you.
Well, I'm going back to the coordination of care problem and interoperable data. Make the foundation. That's what government's role is.
Thank you.
Yes, two core things. Nobody wants to give away money and trust for no reason. So there has to establish trust within the population to AI in medicine. Secondly, the security factor. There are discussions about blockchain, which seems to be very on a new level. And third of all, we have to be open to new technologies and don't stick to old ones, but because there is a lot of potential, but we are still, I don't know why. If I knew, then I would tell you.
Improving digital health literacy across nursing schools and medical schools, going all the way upstream, training our doctors and nurses for healthcare for the future. They've been trained for an analog world, now a digital world. And then in the UK, we have 1.4 million people working for the NHS. So rather than having a handful of managers trying to implement digital, you have 1.4 million advocates for digital and better education, better awareness, hopefully to fight that resistance and that fear. But if doctors and nurses are not equipped to have the right conversations because they've not been trained to have the right conversations around digital, they'll never be able to advocate for it.
Thank you. And finally, but no means least.
Having the courage and determination to break up existing silos and old structures and liberate in a citizen-centric way the data to innovation.
Fantastic. Well, thank you very much. If everyone joins me in thanking our panel, I think we will save the world together. So thank you and good afternoon.